So we've been able to experiment in what a focus area can look like for health over the last 6 months, and thanks to the generosity of the California Healthcare Foundation. And before we get to some of the concrete work that's been taking place, and some of my other colleagues come out on the stage, I wanted to share with you 2 things that we heard from those of you working on the ground already, working to instill health as a culture in your communities. First, while few of you are actually in the business of healthcare, pretty much all of you, if you work for, within, or with a city, are in the business of health. And there's significant opportunities and challenges ahead of us if we're all going to start acting that way. When I took care of patients in safety net hospitals around the Bay Area, we saw again and again the same people coming into our emergency rooms being admitted for the same diagnosis. And we knew that many of them had little hope for a better future than the past that were bringing them back to our facility over and over again. And there was often little we could offer within the 4 walls of the hospital to solve some of those problems. Our country's received a lot of flack for being a sick care system instead of a health care system. And often it's attributed to how we pay for care, volume, not value, also known as fee-for-service, although thankfully that's changing. But the thing is, it's not just how we pay for care, it's also what we pay for and what we consider health and health care. A lot of you know that we spend more as a country on health care than any other country in the world and receive quite a bit less health than most others do for that money. What's less often spoken about is how we're tragically underfunding our social safety net and social programs that also have a significant impact on health. You can see in this graph that we actually spend less than any other developed country, and many other developed countries have an inverse ratio in place where they're spending significantly more on their social services than on their healthcare system. We have to change the way we invest in healthcare and health within our communities and how people work together within our communities if we're really going to move the needle. And I know Esther Dyson is here with us today, and I think Wade Wellville is a perfect example of how you can bring many people to the table to work on this problem. So many of you are affecting health in your communities because you're working on bringing in access to healthy food and places to exercise. It's because you know that children who have access to healthy food and a safe place to play are 52% likely to be obese, and those same children are less likely to have weight trouble in the future or deal with chronic disease as an adult. It's why so many of you are doing things like bringing in grocery stores to previous food deserts, as we heard about yesterday. It's why so many of you are bringing in farmers markets and ensuring that people who use food stamps can actually spend that money at farmers markets. And it's why I know several hospitals in the Bay Area are working with social service programs to actually prescribe healthy food and prescribe specific types of activities, even to the extent of specific hikes for their patients. Many of you are in the business of health within your communities because you do tons of work to bolster good mental health in your community. Just the fear of crime alone can cause people to pull back from the relationships with family members and friends in the social fabric of their community. It hurts their mental health, and it causes them to move less physically outside of their home. And many of the rest of you are working within public health agencies, social services, departments of that type that provide a lot of services when something does go wrong that the health care system can't even begin to address. The second thing that many of you have taught us, and that has sort of become the theme over the last day or so, is that we must start embedding dignity by default within the services that we provide to our most vulnerable, often when they're at their most vulnerable. I was struck yesterday by the number of presentations that started with people standing in line. Does this really become what we think of when we think about receiving government services within our country? I truly hope not. So one thing we heard and again, that it's about respecting people's time. It's about respecting that mother who has a job that her family deeply depends on, but that's already unstable. We can't ask her to wait on hold for 30 minutes when she has to call in the middle of her workday to make an appointment for her child to see a pediatrician. And we definitely can't ask her to take the entire day off of work each time that child needs to visit the doctor, because she can't depend on whether or not she's going to end up waiting in the waiting room for 30 minutes or 3 hours. We heard from many of you that we have to stop making people feel like it's their fault when they can't navigate rigid and complicated systems just to get something really simple. It's really funny when it's Seinfeld, right, and soup, but it's not funny when it's food stamps or access to health insurance. And you told us that embedding dignity by default is not just about the people who receive services, it's the people who are the public servants within our systems, who often have inadequate tools to get the job done, and then they themselves feel inadequate because they can't do a good job for the people that they're trying to help. So something that we hear often within this body of work, and that I've heard from many of you, you hear often too, is, Why are you working on this sort of interface problem? It's not really the important stuff. Yeah, it'd be nice if things were pretty, but get to the meat of the problem. And I'm here to say, and you've told us as well, that design is absolutely not only making things pretty, although that's nice. Design is fundamentally how things work, and that's why human-centered design is so important. And I think all the capabilities that CFA is now working on are incredibly important, but especially within health and healthcare, we often need the most help in this particular area. Because when human-centered design is not in place within health and medicine, things can go very awry. We can make mistakes. We can take out the wrong kidney. We can prolong human suffering, as we're seeing, unfortunately, within the VA system, as people struggle to get in for mental health treatment. We can even kill people, as has happened when medication order forms are so confusing that the wrong dose is administered to a child or somebody who's very ill. And many of you are already working on this problem within your communities. You're working on health and dignity by default in San Francisco, when you're using text-based messaging to interact with people and help keep them on their food stamps, as Jen spoke at length about yesterday. It's programs like Open Notes and Blue Button in communities and organizations across the country who've decided that it's unacceptable for people to have barriers in place between themselves and their own health information. It's the state of California who's decided to make it much easier to apply for both Medi-Cal insurance and their CalFresh food benefits program at the same time through the Express Lane Enrollment Project. And it's all of you that are embedding dignity by default into the tools that all of you yourselves are now trying to use in your day-to-day work, and that we'll hear more about an example of from Long Beach in just a few moments. Code for America is very excited to embark upon this adventure within the focus areas with you all, and I hope I've convinced you that all of you have a significant role to play into embedding health and dignity by default in your community.